I'm hoping this is going to the right Facebook account. Thanks everyone for your patience. Great, so we are on Facebook. We are streaming live, it looks like. And now I have to go back to the stream. Okay, so we are live on Facebook. We're recording this event and it is 6 p.m. Great. Well, thank you all for being here. My name is Lisa Reynolds, and I'm a pediatrician with the Children's Clinic, who is the kind of the proud sponsor of tonight's event. We're calling this event Kids and COVID, and our topics tonight will include everything from do kids get COVID, as well as COVID vaccines for kids. And I think the question on everyone's mind now that it's almost September 1st, which is the return to school and how to do that safely. Before we jump in, I would like to do a land acknowledgement. I'm grabbing my paper because I don't have this memorized. We are currently seated on the traditional land of the Yali Tualatin, the Wasco Cowlitz Clackamas, and the Kalapuya. Indigenous people have played a large and important role in shaping the world and in shaping Oregon. And so we want to make sure we acknowledge them before we get started. I also just a few housekeeping things is we are not going to have available like an open chat where people can all chat to everyone and to each other. But if you have questions, please either send a direct message through the chat to myself, Lisa Reynolds, or to staff, also known as co-host. And without further ado, I would like to, first of all, introduce my special guests. Dr. Carolyn Shelak, she's over here on my screen, but I know it's all different. And Dr. Wendy Hasson, and these fine women and great guests are both pediatric ICU doctors. So they take care of the sickest kids in the state. And they have their finger on the pulse of what's happening at the hospital level for kids. And it turns out, as I learned on social media, they actually take care of some adults. So what I'd like to just first say, and we're going to try to keep this pretty casual between Carolyn and Wendy and myself, is, one thing that we know right now, anyone who's reading the news, and I do know we have people from other parts of the state, and I know everyone in the country is really hurting from this Delta variant, but Oregon is being hit very, very hard. Oregon is one of, I think it's 5 states, the last time I looked, where our spike now is much higher than our highest spike back in the winter. Part of that is because we moved heaven and earth to keep the curve flat in the winter time, and now with the Delta variant, it's almost impossible to do that. And I will share that there's a little bit of frustration around this because I know we all wish we could have done better as a state and as a country in getting vaccine rates higher, and we might not be in such the dire state that we are now, but we are here now, and we want to help you navigate where we are. So COVID numbers are climbing precipitously, both in the US, but also especially in Oregon. And COVID cases among kids are also climbing at a rapid rate. In fact, kids are making up a higher percentage of our COVID cases than they have in the past. And that's been seen across the country as well. Hospitalizations among kids are also rising. And I think, and actually Carolyn, Wendy, correct me if I'm wrong, I think that's more just the pool is bigger, right? And actually, let me ask you guys that. It sounds to me like the jury's still out as to whether the Delta variant of COVID is making kids sicker. Can one of you comment on that?
I think Lisa, that's correct, that the jury is out. There is some preliminary data from the UK, and maybe Israel, maybe suggestive of some increased severity of illness with Delta, but it's really hard to tease that out right now. because, you know, if you have a larger percentage of the population who gets infected, just because of percentages, you're likely to see a small proportion of those be sicker, and the bigger the percentage, the bigger that small percentage is going to be. So I don't think we know.
Okay, great. Well, on that note, I think what I tried to make clear is early on in COVID, there was a bit of a trope that kids didn't get COVID. If they got it, they never got sick, and they never spread it. We know all those things are wrong, that kids do get COVID, they can spread it, and they can get pretty sick from it. But I would now let Wendy talk. Tell me a little bit more about that spectrum of illness and what you all are seeing.
Yeah, absolutely. So, you know, unfortunately, kids do get sick with COVID, I think is the bottom line. I think, you know, the one thing that I do want to make clear is that, you know, I think there's a lot of fear right now. And I think it's important to remember that the vast majority of children are going to do just fine. But it is true that kids do get sick with COVID. And if you look at the most recent studies, they're estimating that about 1% of children who have COVID will require hospitalization. And it actually might be even a smaller number than that, because I think there are so many children who are have small enough symptoms that they don't get tested or are completely asymptomatic. I think there's a lot of kids running out there with allergies that actually have COVID. So the numbers may actually be lower than that. But right now it's about 1% of children who are being admitted with COVID. How sick they are really depends. We're seeing some kids get admitted to the ICU with really severe pneumonias that require them to be admitted for you know, a week, a couple of weeks. We're seeing kids that can come in with COVID affecting their brains, which is something called, you know, encephalitis, where they get swelling of inflation of the brain. And to be honest, a lot of what we're seeing is actually not what we call acute COVID or the COVID pneumonias that you think of in adults, but a lot of what we're seeing is actually something called MIS-C, or the multi-system inflammatory disorder, which is basically what we call kind of post-COVID inflammation. And essentially what that is that's kids who had COVID. A vast majority of them don't even know that they ever had it because their symptoms are so mild, and they come in with high fevers and full body inflammation. And those kids can be quite sick. And we can talk a little bit more about what that looks like. But what's important to say is that, yes, kids can get admitted with COVID, and we are seeing more and more with that as kids are getting back out into the universe. And I think we're going to see more of that when kids start school. And I'd like to spend a moment touching on, I think probably a lot of people have heard the media say, well, you know, most of these kids have, you know, pre-existing conditions. And every time there's a new story about a kid who gets hospitalized for COVID, the first question people ask is, oh, well, did they have pre-existing conditions? And, you know, I think number one, I'd like to say as a pediatrician, oh, it breaks my heart, because when did we stop caring about kids with pre-existing conditions, right? Like, I care about all children, pre-existing conditions or not. And number two, I want to clarify what people say when we mean pre-existing conditions, because I think a lot of people have in their head that these are kids who have these, you know, rare genetic illnesses or kids with cancer. But actually, the majority of kids who are getting admitted with these pre-existing conditions are common things that kids have, such as obesity. 20% of the US pediatric population is obese. A lot of them have, you know, type 1 diabetes. That's not uncommon. And a lot of them have asthma. There's over 6 million children in the US that have asthma. And I would bet that there's a few people who have kids on this phone call that have asthma. So those are the pre-existing conditions that we're talking about. And that's about 60% of hospital admissions. But I'd like to point out that means 40% of hospital admissions are kids who don't have any of those things.
Thank you for that. And someone did ask me a question about, are PICU beds filling up in Oregon? We're certainly hearing about Texas, Florida, some of the other southern states. What are you guys actually seeing on the ground in terms of intensive care unit patients from COVID, or just overall how the ICU is doing for you all?
So the irony of COVID, the first 18 months pre-Delta was the good thing, as you mentioned, is that most children were not affected by COVID. And with the social distancing and school, virtual and long distance school, children were not mixing. So we actually saw a significant decrease in ICU admissions overall. We certainly still had ICU admissions for trauma and sort of the things that don't change in terms of infectious risk. But what we're seeing now is for us in our ICU in August, we actually had higher pediatric ICU numbers tend to be cyclical. We tend to have a lot of admissions in the winter when children get all of the winter viruses, and we tend to have fewer admissions in the summer, and that's as it was and always shall be. But we were having numbers in August that were similar to more like November or December numbers in the pre-winter viral season. I think though it becomes, and to your point, that was when we started trying to help out our adult colleagues by taking adults up to a certain age with disease processes that we felt like we could manage appropriately as pediatric intensivists to help offload them. Now, though, we're seeing things that are complicated not only by higher physical numbers than we normally would see for the year, but by the fact that our staffing in general in the state has been severely affected by COVID. We've lost a lot of nursing staff and physician staff as well, but that's less of the problem right now. We've lost a lot of nursing staff because of burnout, because of early retirement, other things. And so while in theory we have, I want to say 48 pediatric ICU beds in Oregon, there have been times this summer where we have not had the nursing staff to be able to fill all of those beds if we needed to. And that has, I think that has us worried for what the winter is looking like. So we're of course doing everything we can to augment that staffing. But part of everything we can is also to try to keep children from needing those beds in the first place. And that's where some of the mitigation opportunities can help us. Hopefully we as a community can get this to a more workable place.
Yeah.
Yes, I think that's a good segue. I think I want to ask you guys one more question. I mean, I'm going to be asking you tons of questions, but do we know anything about long COVID in kids? And I will tell you, when I looked it up, it was difficult to find stuff. I will say that I had a patient in our practice who is heading off to college as an athlete. She's a college level soccer player. She got COVID in January, so before the vaccine was available to her. And in June, she still couldn't smell. And I was just shocked. She was otherwise doing okay, thankfully. And she's like, it really is hard to not be able to smell and food doesn't taste good, and I guess technically that would be long COVID. I mean, the stuff we're more worried about is what we're hearing from the adult literature, which is the brain fog and the fatigue.
And the cardiac.
We know what's happening with kids in COVID, and I suspect there's gonna be a lag before we do, but.
Yeah, that's a good question. I mean, one of the hard things is that it's actually really hard to study long COVID because long COVID can mean a lot of things. Some kids just have this brain fog. Some kids have fatigue. Some kids have long-lasting headaches, etc. So it's really variable. I've seen studies that estimate it anywhere between 5 and 15%. And so I think that's a new frontier for pediatrics. And I think that now that kids are going back to school and we're going to be seeing a higher number of particularly teenagers being affected, I think that is really to be determined. But I think that I'd like to use that as a segue, Lisa, to another point, which is that all of these things that we're talking about, long COVID, MISC, the inflammatory syndrome, the pneumonias, all of those things are more common the closer you get to adulthood. We're seeing these things, hospitalizations, severe illnesses in primarily adolescent patients. And you know, Carolyn and I have trained our entire lives to take care of kids in the hospital, but what we're actually really passionate about, and Lisa too, is keeping kids from ever having to see us, right? And so one of the things that I think, most saddened by is that every patient I have that's admitted to the ICU between 12 and 17 years of age has what now I consider to be a vaccine preventable illness. And right now, the last time I checked, which was earlier today, the vaccine rates for patients who are between the ages of 12 and 17 was only 45% in Oregon. And in some places like Multnomah County, that's much higher. That's much closer to 60%. But there's still a lot of kids running around out there that have a vaccine available to them that are not vaccinated. And so the biggest thing that we can do to keep kids out of our ICU and to keep our ICUs offloaded is to get these kids vaccinated.
And I'll add to that, Wendy, not only have them be vaccinated, but have the adults surrounding them be vaccinated. And that's important whether you have a teen who's eligible for the vaccination, because, you know, we know, despite our hopes, that people who are vaccinated not only can contract COVID, but they can then be infectious. We know that the infectious period is shorter. And we know that the infection itself is much less serious most of the time when one is vaccinated. But, you know, the more we can surround our children by a bubble of vaccinated, vaccine eligible people, it again is one more layer of protection to add to them.
It is. And I'd also like to point out that we have not had a severe case of COVID that was vaccinated. All of our adolescents who have been admitted to the ICU have been unvaccinated.
Correct. And same with MISC. You know, for most of those children, most of our MISC patients presented in children either in adolescence before the vaccine was available, or in children who were less than in that sort of 8 to 12 range, where they're still not eligible for the vaccine. It'll be interesting to, not in a good way, but it'll be interesting to see. I think, you know, Wendy and I have been, I think we are all in the hospital anticipating that we're going to see a surge of MISC probably around November or December, in that 8 to 10 week period after there are, you know, community COVID cases in children. And it will be interesting to see whether or not those children also received the vaccine or not. And I think all of us are fervently hoping that vaccinated children, even if they contract a breakthrough COVID, will hopefully be protected from the MISC post-infection. But it's too early to know that right now.
I think that's an interesting point. And you know, MISC, we've had 40 cases in Oregon, and I don't want to spend tons of time on it, but I do think it is important to note, as you said, Carolyn, that you can have a totally mild case of COVID, maybe even an asymptomatic case of COVID, and 2 months later, you can be one of the sickest people in the pediatric ICU. So we're all moms here. So if you as a mom or parent have a hunch that something's really off with your kid, this is just something we all have to think about, certainly in pediatrics. And I know you all are thinking about it. And when I first met Wendy and Carolyn, we talked about that. I found it really scary. And I think it is, I want to now, we've kind of slowly shifted gear, and I want to go full bore and talk about the vaccine a little bit. And I love how you said, Carolyn, that we want our kids, and I would say especially our not vaccine eligible kids, those under 12, to be surrounded by people who are vaccinated. Mm-hmm. And I can't tell you story after story of what I'm seeing in terms of kids getting COVID. It's usually from an unvaccinated source. One I saw today, a whole family got COVID. The kids were too young to be vaccinated. The parents were vaccinated. It was from an unvaccinated neighbor. So mm-hmm. That is a really important layer of protection. That's why it was so crucial for Governor Brown to require that essentially all adults in the school building be fully vaccinated against COVID by October 18th. My understanding is most of them are by now, but it'll be for sure by October 18th. But let's talk a little bit about, I know people are concerned about the safety of the vaccine. people say this is a new vaccine. It's genetic material. I know you two are doing some town halls through your work at Randall Children's Hospital, talking to families. And I forgot to mention that Wendy is the medical director of the Peds ICU there. What do you say to that?
I'll give a few talking points and I'll hand it over to Wendy, because I think she could, she has a lot of great thoughts on this, but I think a few things. First, I think one thing that I've heard many people say is this was rushed. This was the fastest vaccine approval in the history of, vaccination development. And I think the thing to remember is that despite that this speed does not mean inadequate study. Over 40,000 people were involved in the initial trials for the Pfizer vaccine. I know the numbers for Pfizer are better than Moderna, so I apologize, I can't speak to that, but over 40,000 people. That's by far and away bigger than any vaccine study cohort that's ever been done in the history of vaccine development. And I think it's worth remembering that the reason why this vaccine was able to be developed so quickly, and I mean, to me, it is a testament to the scientists and laboratory technicians and all of us nerds, all of the nerds that just, I'm sure, lived and ate and breathed this vaccine for the 9 months it took them to get it out. They were able to do things more quickly for a number of reasons, none of which are shady. Number one, there was a lot of money available to get this going. Number two, they were able to do steps that, again, often because of resource limitation, often would go sequentially. They were able to do those steps in parallel, so that sped things up. And then last, you have to remember that for many vaccines, in order to show that it's both safe and efficacious rather, you have to have a certain rate of exposure of the disease. So if you're trying to do a vaccine against, I'm just going to make this up, but let's just say you're trying to develop a vaccine against Ebola. There's not, fortunately, that many cases of Ebola out there. And so in order to have enough vaccinated people exposed and to prove that it works, that's going to take a long time. For better or for worse, we had a lot of COVID. And so the rate of exposure could be fast enough to show efficacy very quickly. So I think there are valid and supported scientific reasons that this went quickly. That does not mean that it wasn't done well. I just, again, I think it is a testament to the fact that when humans put their mind to something for the good, they can do amazing things. So I'll stop there on the study design.
Yeah, that's a great point about the ubiquity of the virus. So you could really see the difference quickly.
Right.
Yeah. I think, yeah. And I want to say, I think actions, in some ways actions speak louder than words. And so, I always tell people, I'm like, I have no horse in this race, right? Like, I don't have like some Pfizer, Moderna money coming in, right? I went into pediatrics, one of the lowest paid medical specialties, because I love children. I care about children. I want children and families to be well, right? So see what I do. Like, I was the first in line, literally, actually, Carolyn and I, on the first day that they offered vaccines in Oregon, Carolyn and I were there together getting our vaccines. I was up at all hours of the night trying to get everybody I know appointments to get vaccinated as soon as possible, trying to get my nieces and nephews into vaccine trials. I mean, I am so confident in the safety of this vaccine that I am doing everything I can for everybody I know to get it, right? That's what I want. And I also think it's important to know, just to Carolyn's point, that this is really the most carefully watched vaccine rollout in history. And I want to point to a specific example that I think really speaks to that, which is that, looking at the Johnson & Johnson pause from a few months ago, all of a sudden there was this concern that maybe there was some increased blood clots. And, if you looked at the number, I think when they did the pause, there were 5 cases. There had been 5 cases reported in the United States. And the FDA said, no, time out, safety first. And they took almost a month-long pause to really study Johnson & Johnson. And it's the same with the COVID rollout for kids, I was hoping for an early fall COVID vaccine rollout for kids. But the FDA said, nope, safety first. We want to double the amount of kids that we're requiring you to enroll in your trials before we will look at your data. And so I think that there really is a commitment of safety from the FDA.
Thank you. Thank you for that. I mean, and I think, Wendy and Carolyn and I have talked about, like, can't they go faster? I think every pediatrician, especially as we see school looming. But I do want to just kind of close with a few things here on the vaccine part, then we're moving on to school. And that is that we certainly know that the risks of the vaccine, the J&J blood clot was a great, in the end, the risk of blood clot from J&J was no different than people who got the placebo, so to speak, or what was in baseline in the community. So we want, what I would love for everyone to leave here today is, first of all, to have confidence in the vaccine, that it's safe, so that if you're eligible or someone you love is eligible that hasn't gotten it yet, you will get it. I'm having people, of course, ask me, well, what are you going to say about the 5 to 12? And what I'm actually saying, I am going to wait, and I'm going to watch the science too. If it's anything like we learned with the adult version and the 12 to 17, I'm going to be all in, but I'm going to watch the science just like we all are, and like the FDA is.
Yep. Lisa, should we just touch on myocarditis?
Yeah, and then I was going to ask about the risk of I think that's where I was going. Thank you. Take it away.
Okay. I want to make sure that we just spend a few moments talking about myocarditis, because we've been saying this vaccine is safe, this is safe, but we also know that there is a warning that these vaccines can cause myocarditis. That is true. And what that means is that these vaccines can cause some kind of low-grade inflammation of the heart. We're seeing that primarily in teenage boys. It's actually almost entirely, like 90% teenage boys. I don't know why boys got to be special, but there you go, who knows? And when this started happening, we started watching this really closely. Initially, we were admitting all of these patients to the hospital to monitor them. And what we learned is that actually this is entirely a low-grade inflammation. So some of the patients will present with some maybe chest pain or chest discomfort. And we find that when we measure their cardiac enzymes in their blood, that those are slightly elevated. But what we found is that is self-resolved. These patients have echocardiograms, and we take pictures of their hearts that show that their function is normal. And the vast majority, if not all of these patients, recover without any intervention within a couple of days. And so we've actually started just monitoring these kids at home and not admitting them to the hospital. So yes, it is possible, and definitely well documented that can happen. But at least in my mind, that is knowing that somebody could have some chest pain that will resolve in a couple of days, for me is, I would take that any day over what I've seen from healthy adolescent boys admitted to the PICU with COVID.
With more severe heart inflammation, right?
With much more, yes.
Correct.
And we actually know that the heart inflammation that you can get from COVID is much more significant, much more longer lasting. I've had patients with COVID related heart disease admitted to the ICU on continuous drip medications to support their heart function. They have to go home on medications to support their heart function. So that is a very serious thing to get heart inflammation from COVID.
And I would just add that we don't know yet, because the number of children who get COVID is fewer than the number of adults. So this may not extrapolate, but there is some early data suggesting that in many adults with COVID, even if they had relatively mild to moderate diseases, they do potentially have some cardiac inflammation or cardiac dysfunction down the road. So it does seem like the virus seems to really enjoy, in some people, is it a genetic predisposition? Who knows? But it seems to really target the heart. And so I 5,000,000% agree with Wendy that taking your chances with what kind of cardiac dysfunction you might get after COVID infection, I think is much riskier than the very few cases of myocarditis in the vaccine. And just for numbers for people to try to wrap their brains around, when Pfizer reviewed their data for myocarditis, and I don't know if this was, I guess it was Pfizer because Moderna is not down to 12. They saw 16 cases of myocarditis for every million second doses, because it does seem to be associated more with the second dose than the first. So 16 cases for every million second doses of the vaccine above the expected community rate. So that's not to minimize that. And for those teens who develop myocarditis, that's a significant event in their lives. You know, we'll never know though, would those teens who got myocarditis from the vaccine have been the ones to get really severe myocarditis with active COVID? You know, we just don't know.
Yeah, and my numbers I saw, and this was out of one of the ID doctors at St. V's, is that 1 out of 40 cases of COVID actually have some heart involvement. So, you know, whatever, 1 out of 800, whatever, 16 out of a million versus 1 out of 40. Even I know that's a bigger number. So,
Lisa, would it be good to just touch for a moment on the concerns for infertility, since I've been
yes,
hearing?
please.
Sure. So one of the other common concerns about the vaccine that I've been hearing from families is that there's been a lot of misinformation about the possibility of these vaccines causing infertility. And I think it's a really understandable fear that parents have. I mean, you want to protect your child, but the worst thing you would want to do is prevent your own child from being able to have their own family. So I think that that's misinformation that really preys on a parent's, like, really just pulls on your heartstrings, right? And I just think it's important to say that there is absolutely zero evidence that these vaccines are associated with infertility. In fact, there have been hundreds of babies born already to people who have gotten the vaccine. And once again, you know, actions speak louder than words. You know, I have a 2.5-year-old son, and my husband and I plan on growing our own family. And I happily lined up to take the vaccine because I'm so confident that taking this vaccine will only protect me as somebody who wants to have another baby in the future, and as somebody who wants to grow my family. And I have no concerns whatsoever that it would prevent me from doing that.
Thank you for that. I think you're right. Some of the I'm just going to say it. Some of the propaganda that is trying to persuade people not to get vaccinated is really well put. Like, right, you're allowing your child not to have a child. You know, thank you for that. And I guess I would just, you know, put a plug to everyone here to think about the people in your life who are nervous about the vaccine or vaccine hesitant, and really just take time to listen with empathy and without judgment. And it may take 2 or 3 conversations, but these conversations with trusted friends, family, physicians, you know, religious communities are what is going to help us all improve our vaccination rate, which, as we'll keep saying, helps that particular person, keeps that particular person out of the hospital, and really helps our community in preventing the spread of COVID and the current crisis that every single hospital in Oregon is suffering. Let's talk about school. And my staff is putting a little thing in to how to find a vaccine. Let's talk about school. So tomorrow is September 1st. I know that some schools are starting September 1st, some are starting September 8th, some are doing some graduated starts. What are the main things that we know will help keep kids safe in school? I'm going to start with vaccines. We've already talked about vaccines, certainly for all the adults in the building, and certainly for any student who's eligible to be vaccinated. That is not currently required, but I think it's something we absolutely have to look at. What's next? How about Carolyn and Wendy? We could do a popcorn.
Sounds good. You know, I think before I comment on things that can help, I do want to just I want to say that, you know, we did have some children in-person school during the school year last year. And we also have a lot of data from daycares and preschools that never went, you know, that remained open. And they did a lot of, we call them mitigation factors, but we'll just say safety maneuvers that really helped limit spread in the childcare and especially grade school setting. High school can be a little bit different because, again, of the teenage population. We'll put that to the side. But I do think it's important to unfortunately remind everyone that Delta ups the game a lot on this, because it is so much more contagious and takes such less exposure, both inside and actually, unfortunately, we think also outside, which is, we had been told, and I think we lived and learned that before Delta, outside was very, very low risk. And, I let my children play outside with play dates all through last year, masked, just to be safe, for what that's worth. Anyway, so keeping in mind that if anything, unfortunately, because we're all tired, the safety things that we want to have in place, we actually need to up our game a little bit right now with Delta. And I think you can think of it as sort of trying to put 4 or 5 slices of Swiss cheese together so that you don't have any of the holes aligned. And those slices of Swiss cheese are going to be masking. And I know that is a very hot topic. And there's a lot of passion around masking. I think the few things I would say to that are, there are very few instances in which masking is dangerous. I think children are very resilient. And I think if it's a choice of having them in school in a mask versus in school without a mask getting sick, so then they're not in school or home, I think most children would choose a mask. And I think if you start them young and you make it a not big deal, children can tolerate masks. And I even before COVID, I wore masks for full 16-hour shifts, and it is doable. It's not fun. But, again, I mean, I talk with my girls a lot about, I know masks are no fun. And would you rather go do your activities with a mask, or would you rather not do your activities? And hands down, they will always choose to do their activities with a mask. So masking, number one, for everyone, vaccinated, unvaccinated, because it's going to, and I know there's been a lot of misinformation about masks only protect other people around you. I think masks protect the wearer as well as other people around you. And so again, when you have 2 people who are masked, you have better protection for everyone. Distancing and hand washing are also important. Probably not as impactful, unfortunately, now as they were with the pre-Delta, but still important. And I think where distancing is very important is when you have communal activities where masks are off, and the biggest one for school children is going to be lunch. And that also goes into ventilation. And that's where, again, if you have a good ventilation system, that's going to be better than one that doesn't have good ventilation. That can be as low tech as opening windows. A lot of schools have been retrofitted with HEPA or other filtration systems that certainly help. And being outside, if you can't ventilate, or if you need to be in a larger group where masking is not going to be possible for things like lunch. And then the last, which is a little bit more controversial because there are some pros and cons, is scheduled testing of entire cohorts. And, we can go into that in more detail. And I think the last thing I'll say, and then, I'll pass it to Wendy, is that I think the other really important safety factor, that's maybe not a factor, but is a factor, is our ability to hopefully have continued flexibility right now. It is best for everyone in a school if your child develops a runny nose and a cough. Pre-COVID, I mean, I don't know about you guys, but pre-COVID, if my kids didn't have a fever or were not bleeding or actively throwing up, they went to school, right? You're fine, you go to school. And that's absolutely not how we can play this right now, because we need to know that we're not sending a child with mild COVID symptoms to then spread it around. That's, practically speaking, I get it as a working parent, that is so challenging to be able to navigate keeping your child home, testing, when do they go back? Do we have to quarantine if they get COVID? Do I have to quarantine? It's a lot to navigate. My hope is that we're gonna be able to vaccinate school age children by the end of the year. And that's not going to make the problems go away, but I do think it will be a little bit easier. So I think for the next 6 months, we're just going to all have to hopefully as a community try to be flexible to try to keep our own children as well as other people's children safe. So I'll stop there and see what Wendy has to add.
Great, thank you. Wendy.
I think Carolyn really touched on a lot of the safety measures. I think she really touched on all of them. Great job, Carolyn. But so I'd actually what I want to talk about is actually the distress that parents are feeling about sending their kids back to school. I mean, I can't tell you how many people have messaged me and are like, I'm thinking about pulling my kid. I'm thinking about pulling my kid. What should I do? What should I do? I mean, this is, I think, in some ways, the most distressing time to be a parent in this pandemic. And I think what a lot of people have voiced is that people feel like now, we're sending our kids back when Delta's coming. And is this the worst possible time to send our kids back to school? And I hear that a lot. And so I want to speak to that kind of despair and say, keeping our kids home last year was not for nothing. And sending our kids back this year, even though we have this stress of the Delta surge, we are in a different place than we were a year ago. And, now we have the ability to have vaccinated adults around them. We have the ability to vaccinate the highest risk kids, which are the 12 to 17. And most importantly, we know so much more about how to treat patients that come in with this. I mean, a year and a half ago, we had no treatments for COVID pneumonia. We didn't know how to best treat these patients. Whereas now when I get a call, I'm like, okay, COVID pneumonia, great. Like I have this. I have these tools in my pocket. I know what this looks like. I know what to expect. I know how to counsel parents. And so I do think we have some tools in our pocket that can help us, we're working on availability of monoclonal antibodies for patients who are exposed that are greater than 12, which is not currently available in Portland, but may be. So I think that there's some light at the end of that dark Delta tunnel that people are feeling. And this is my personal opinion, but I've spent a lot of time talking to Carolyn, and I think Lisa would agree. I believe, and I live and breathe COVID all the live long day, and I see the worst of it, but I absolutely believe the right thing to do is to send your kids back to school, because you know what, there's no free lunch. And even though we're all worried about COVID, not having kids in school has its own ramifications. And we've talked a lot about COVID hospitalizations, but I can't even tell you the peak that we've seen in adolescent intentional harm and suicide. And it is not natural for adolescents to be separated from their peer group. And I think it's really important for that group to be back in school. And that's the group that can be vaccinated and sent to school most safely. So once again, vaccinate your kids to send them back to school. But I do think sending kids back to school is right. And I think that we're really lucky to be in Oregon because, say what you will about Kate Brown, but I have to say, I'm really happy with how she's done the back to school situation, mandating teachers to be vaccinated, mandating masks. That is the safest way to get kids back to school. So I think we're lucky to be in Oregon.
Thank you for that. Yes, absolutely. And I think I just keep coming back to like vaccines for all eligible, ventilation. I will tell you that I sat in on a Portland Public School kind of rollout. Was that yesterday? Yes. I mean, they're saying every classroom has the HEPA filter and that all their HVAC systems have this MERV 13 filter. Those are things that continually circulate the air in classrooms and filter out particles that COVID virus travels on. The masking, of course, I want to say just one word about masking and testing. And then also we are all going to be watching, right? We are, I don't know, when my kids were younger, I'd be like, okay, the school year's here, go, bye, see you in the fall or whatever. And I will say my kids are grown, my son's in college and my other son has graduated college. So I'm not having to do the mental gymnastics you all are. But it's we're going to need to be watching, and when you're going to need to be reading those bazillion emails from the schools, and we may have to correct course. We may. I hope we don't, but that's where the flexibility comes in. And also, I talked to a family today who is going to take a trip with their kids who are too young to be vaccinated. And I said, you know, when you come back from that trip and they're going to take a lot of safety precautions, I told them I probably wouldn't take that trip with unvaccinated kids. They're not going to Disneyland or anything. I said, you know, just to be a good community member, it might be good for you to hold your kids home for 5 days, make sure they're testing negative before you send them back to the classroom.
Yep.
That's not required by the schools right now, but that's just, let's all be like really good community members, which also goes back to everyone vaccinating. On masking, I'm wondering what, you know, there's been a lot written about what masks work better than others. And one thing that I've been telling families is like, well, first of all, it's got to be a mask your kid's going to keep on their face. And kids are great at masking. This whole thing of certain adults saying, oh, that's terrible to make our kids mask. Kids come into my office all the time. Granted, they're only with me for 20 or 30 minutes. Their masks are cute. They've got animals on them. So kids are fully capable of doing this. But my understanding is the disposable surgical masks, which I have right here, are better than just a simple cloth mask. The cloth masks are better if there's 3 layers, if you have the nose wire, which all of the surgical masks do, and if you can adjust the ears. And then there's the kids kind of N95 masks. Do you guys have any strong opinions on those? Or I guess Carolyn can maybe start sharing, because I think her kids will be in elementary school, right, Carolyn?
Yeah, yep. So first I would say that, staff, I can share, I have a sort of a synopsis on some mitigation measures and masking in particular that I can share with staff that we can post. A few things on masks. And yes, I have 2 girls who will be starting 5th and 2nd grade. So they're 10 and 7.5. It's important to get that half in there. And so they're too young to be vaccinated. And I you know, I will be very frank with everyone on this webinar. I've certainly had my sleepless moments of, am I doing the right thing? Because my children were home until they were home for a year. They went back in full-time in person in April, and it went very well. And so I'm hopeful that that will continue, but I've certainly had my sleepless nights. And to Wendy's point, I've just kind of come to peace with the fact that there's risk in life. There's risk in life. And for my children, the mental health risk of being home was going to be far greater than I think, and I hope sending them to school, especially knowing that we have all these safety measures in place. So to masks, just super briefly, the most important things about masking are, to your point, Lisa, that the child will keep them on. Because if they have a mask hanging down under their nose, you know, half of the protection is gone for them, as well as their, you know, their schoolmates. Fit. So a tight fit, not just over the nose, but under the chin. So part of what can be challenging with surgical masks, especially for people like me with a small face, is that you get gaps here and there. So that's where some people have recommended a surgical mask, then a cloth mask over, which sort of seals it down. And then you filter through the surgical mask with the cloth mask, keeping it in place. That can get hot though, over a long day. There actually are not technically any N95s for children because they require a certain type of fit, but there are close to N95s. Those are, many people on this call may have heard KN95s or KN94s. And there are KN95s and KN94s that are specifically made for a child-sized face. And again, we can list those, I have no stock in any mask company, but just, you know, in terms of what I've seen and know are approved by the certifying body here in the US, NIOSH, as well as have good fit. And then there are some that are sort of, I guess I would call them like hybrid masks. And some people have heard of things like happy masks or halo masks, and they are, they're a little different from, they're not cotton. They're usually made of a nylon or synthetic material, which for a lot of chemistry reasons I won't bore you with, is a better filter in some instances for droplets and aerosols. And then many of those masks either have an insertable filter or are built with a filter in them, and you can wash them a certain way and reuse those. For what it's worth, that's what my girls wore last year and will wear this year. Although we may do KN94 or 95s. I haven't really decided yet. You know, those are not as comfortable, to be totally frank, as the cloth masks. And so again, I think then that comes down to your own decision making with your family to say, you know, and my girls are old enough to be able to tell me, I'm not going to wear this all day because it doesn't feel good, or yes, I can wear this all day, I'll keep it on. And you know, I'd rather have them have a mask which maybe filters 10% less, but is going to be on all the time.
Right. Great point. I didn't know about that happy mask and halo mask. Thank you. I will look into that.
For what it's worth, happy masks are sold out for like the next 10 million years, unfortunately, across the country, but there's a lot of other ones that are similar to that. And I can share with you, Lisa, I have a couple sources that sort of have, you know, listed ones that have similar properties.
Great. And we can send an email out and also post on the Children's Clinic Facebook page this information over the next day or two. There were a couple questions that, so I think the long and short, I think we've kind of summed this up nicely, which is that we are lucky to be in Oregon, where there's really good control measures in our schools, about as good as you could expect anywhere in the country. Portland Public Schools has a very robust testing program. They want to do weekly testing of people, even if they don't have any, I mean, especially if they don't have symptoms. They're going to have on-site testing for people who do have symptoms before they're kind of shepherded out of the classroom or shepherded out of the school. So what I heard from Portland Public Schools was impressive. I have to think, but I can't know for sure. And our staffer put these links in the chat, but that other school districts will be following suit, I think, in the area, certainly, of what Portland is doing.
Yeah, my understanding, just quickly on the testing, Lisa, is that it's a pilot program supported by OHA with federal COVID grant money. But I think it's, at this point, at least, at the discretion of the school districts, whether or not they want to join those testing programs. I don't know if that will change at some point, but that's my understanding of that right now. So, you know, I would say that if you're a parent in a school district that's not offering that, but you're interested in learning more about whether or not your school district might move forward with that. And, you know, just to reassure people, I believe it is voluntary. They're not requiring every child to be tested. But if that's something that you're interested in seeing whether or not your school district would implement, I think that would be, you know, I would advocate for you to politely query your school board and see if that's something they would want to do, because it will, I think they're rolling it out lockstep because it's sort of in time, you know, development, but for what that's worth. And
my understanding is the Portland Public Schools is going to prioritize the K-5 kids, yes. So the kids who are in the grade schools where none of the kids can be vaccinated. That's great. So yeah, I think, and someone just wrote me, so you're saying with a good mask, I should send my 11-year-old to school. I don't want to say should, these are all personal decisions, but I think we feel it's about as safe as you can be, I think, anywhere in the US to go to school in I'm going to say the Portland metro area. I hope the whole state, because we have the vaccine mandate for employees across the state and the mask mandate, but I can't speak for what every school district is doing in terms of ventilation. Kids love being outdoors. I think the outdoor lunches will be actually a big hit. One person asked, and this is going to make our children's clinic very busy. Wendy, should we test our 3.5-year-old for COVID at the sign of every sniffle, stuffy nose, or cough and congestion?
You're not going to like my answer, but yes.
I know.
Yes,
I
yes,
think it's
yes,
true.
And yes, yes. Yeah. I can't tell you the number of kids that have, you know, just allergies or it's just a cold, who end up testing positive. And, you know, and I think it's, you know, it's a great that, you know, that 3.5 with a 3.5-year-old just has a runny nose that looks like allergies. And that's how it mostly presents in 3.5-year-olds. And for that, I'm very grateful. But from a public health standpoint of protecting, you know, that 3.5-year-olds, you know, vaccinated, but maybe a immunosuppressed teacher, or, you know, I'm not so much worried about the children as I am about the higher risk adults that are around them. Because I think, you know, quite frankly, a vaccinated but yet immunosuppressed adult who's on chemotherapy or on, high dose steroids for some reason is still at much higher risk for having problems from COVID than a healthy, 3.5-year-old. So I think from a public health standpoint, test. And, it's becoming easier. There are now, there are a lot of places that offer it, but there's a lot of at-home tests as well. You can get test kits through Walgreens, CVS sells them. You can have at-home testing kits, etc.
And I would just add to Wendy's comment, beyond the very important public health aspect of knowing if it's COVID, the selfishly important aspect of knowing, especially if it's more in that, even at 3.5, but certainly a little bit older, is we want you to have on your radar the, again, 8 to 10 weeks down the road, could they be having some symptoms that might be concerning enough that that you need to bring in your pediatrician for concerns of MIS-C, or down the road. If I as a parent would want to know if my child had COVID, selfishly, just so that I can know that they're following a normal course and to be able to be prepared down the road. But absolutely, the public health factors are important as well.
No, just to touch on, because I think we've mentioned a couple times about this like MIS-C that can happen weeks later. And so what and I don't want to speak much about it, but what I do want to say is that, because I don't want every parent to be freaked out, like, oh, my kid had COVID and then 10 weeks later their stomach hurts and do they have MIS-C? Like, the hallmark of MIS-C is high fevers that do not go away. So if it's 8 to 10 weeks later and your kid has a headache or a tummy ache, but they don't have a fever, or they have a one-time fever and then it goes away, your kid doesn't have MIS-C. The hallmark is high fevers that are persistent.
Oh, thank you for that. And yeah, that's good to know. The other, yes, I agree with both of you. Like, I would want to know if my kid had COVID or not, which is why if my kids were school age and there was not random, but if there was asymptomatic testing happening, I would opt in. But again, I think that's a personal decision, but I would opt in. I think it's good for my kid. It's good for my family. It's good for the school community to know what's going on. Mm-hmm. That was one of the questions we got. There was also a question about the younger kids, like the 2 to 4-year-olds who maybe aren't so great with masking. Is it causing more like touching and schmoozing to have masks? Or do we think we should do away with masks for kids under 5? And I'm being overly dramatic. Do we,
Sure.
What's that risk benefit in the littler kids?
It's a great question. And I'm fortunate that my girls are, Wendy probably can speak to this better because her son is younger, but I just think mechanically, even if they're touching the mask, they're still not touching their nose and mouth as much with the mask on as with it off. And while aerosol, exposure is certainly the main route of exposure, constantly touching your nose and mouth is going to also increase your risk for contracting COVID. Wendy, I don't know. I mean, I think most of the kids, once they have them on, start forgetting about it, but what's your experience?
Yeah, I mean, I have a 2.5-year-old, incredibly active boy. And so for me, it was really important that he learned to mask. So I always tell parents, and I know that there's, screen time issues, but when I was teaching Abe to use a mask, the rule has to be, if you're going to do screen time, then you're going to wear your mask. If you take off your mask, then your screen time ends. And so it's very motivating, but you're teaching 2 to 3-year-olds lots of things. You're teaching them how to wear shoes and pants and hats and sunglasses, and they don't know that a mask is any different. Obviously there's a variability amongst kids about how well they'll do, but I think it's important, will a 3-year-old leave their mask on for, 7 hours of daycare? Well, maybe not. I'll see what my 2.5-year-old does when he starts tomorrow. But I think it's actually more important from other community exposures. I think it's unrealistic that you're not going to be able to, take your kid to Costco or a grocery store or, other kind of community places. So I think just having that, and any risk you can mitigate is a risk you can mitigate. So just, he may not wear it all day in his small daycare group, but if I can get him to, wear it at Fred Meyer, then, that's one less risk factor. So I haven't given up, but and I don't think we should.
That's great. And I think, and not to tell you not to take your kids to Fred Meyer, but I do think that I personally think we should really be prioritizing school for our kids, and that includes preschool and of course childcare. That we as mothers, let's be honest, it often falls to us if childcare is not available. So in that sense, in terms of prioritizing school, and I think this is a message we've been trying to say all evening, whatever we can do to make that community safer around those kids, keeping your kids away from unvaccinated people, increasing the vaccine levels in the community. And maybe, I hate to say this, but I think we have to rethink the after school art class, if it's an indoor class, with the thought that I'm taking some risk to send my kid to school. And maybe I won't do the art class risk right now. Maybe we'll wait till spring when the numbers are lower. So those are just ways to think about it. And again, everything has a risk benefit ratio, and nothing is risk free. But I will tell you, and this has been lots of reading and lots of work and lots of talking to Wendy and Carolyn and Portland Public Schools, I am really at a point where I feel really comfortable endorsing full-time in-person school in Oregon. And that maybe, and that's my closing line. Why don't you guys have a closing statement, and we'll sign off for the evening.
Sure.
Sure. I think my closing statement is going to be sort of a little bit bigger picture. I was having a conversation with a close friend of mine who's on the East Coast, who's not in medicine. We were talking about we will get through this. It is not always going to be like this. And we have a lot of tools at our disposal. Again, to your point, Lisa, make the risk as tolerable as possible. And we do that risk calculation in our household a lot, and we talk about it with the girls a lot. And we've chosen extracurricular activities that are outdoors or that are virtual or things. But we've decided that school is worth the risks that we can say out loud. And at the end of the day, we all do our best, right? And even pre-COVID, there was always a risk of contracting influenza or meningitis or you name it at schools. Not to minimize the special risk that COVID brings to us. I'm not trying to be cavalier about it, but I 100% agree that I think it's time for them to go back. I think the first 6 months of this year is going to be really hard, but I'm really hopeful that we'll start turning the tide in the spring and next summer. And I think if we can do our part to foster at this point grassroots education and understanding and community around vaccination, then I think we'll all get back to, it won't be the old normal, but I think we'll all get back to a new normal sooner. And I'm looking forward to that.
I'll say that, and this is something I've learned a lot in my ICU career, is that when you make a decision, just because you don't get the outcome that you want doesn't mean it was the wrong decision. And I say that to say, I know that kids are going to get COVID when they go to school. Some kids are, and some kids are going to get sick, but that doesn't mean that you as a parent made the wrong decision. You have to make the best decision for your family with the information that you have right now. And for the vast majority of families, that means going back to school. And, some kids are going to contract COVID. And, if your kid tests positive for COVID, then, don't panic. The vast majority of kids are going to be okay. And if they need support, like the Oregon hospital, we're here for you. Yep. And I know there's been a lot of news stories about bed shortages and this, that, or the other, but I promise you, we are working tirelessly in the background to prepare for all scenarios. Legacy Health Systems working closely with Dornbecker to make sure that we are in collaboration to make sure every kid in Oregon who needs a hospital bed is going to have a hospital bed. So I just want you to know that we commit to the children of Oregon, and what I ask in exchange is that you guys commit to the children of Oregon to do your part and encourage vaccination, which leads me to my closing line, which is that I truly believe that getting people vaccinated is one conversation at a time, because everybody's reason for not getting vaccinated is so personal. There is so much fear, and the fear that that's based on is different person to person. And so I just want to say, I am happy to have a conversation with anybody who has hesitancy, but is truly open to having a conversation about that hesitancy. So I'm going to put my email address in the chat, and I want people to feel free to email me or have their family members email me if they have, sincere openness to having conversations about vaccine hesitancy.
Thank you on that. And I said that was my closing, but I'm going to say one more thing because Carolyn mentioned influenza, and we are getting ready. I think we'll be getting flu shots in the clinic here next week. Let's absolutely try to make this an undramatic flu season. We really need that this year. So everyone, as soon as your clinics have flu shot available, get it for your kids, get it for yourselves. We do not want to be dealing with a spike in flu when we're dealing with COVID. Plus, we just don't want people to get influenza. And the numbers are, some people have said, oh, COVID, it's like influenza. No, COVID has, at least in kids, I think for the last count, 450 kids have died from COVID in the US. And influenza tends to be about 200 a year, I believe. So COVID is definitely much more dangerous than influenza. But let's prevent both of those. So flu shots. Thank
Lisa, thank you.
Much. Yeah, thank you, Carolyn. Thank you, Wendy. Thank you, everyone, for joining us on a Tuesday evening. We are available, and I hope that if you have questions, we put our emails in there. We're happy to watch that, or to watch our emails for questions from you. And then this will be on our Children's Clinic Facebook page, which is TCC Portland. If you have friends you think would want to, who might benefit from this. But thank you so much, Carolyn and Wendy, for all you do and for being here this evening. I'm really grateful. And thank you all for joining us.
Thank you.
Thanks, Lisa.
Thanks.